We're going to pick up here chapter 23 on restrictive pulmonary disorders. So some of the restrictive pulmonary disorders can result from decreased lung expansion. This can come from like alterations in lung parenchyma. You know, if the lungs are less compliant due to alterations in the lung tissue, they can't expand as well, then that could be a restrictive disorder. Otherwise, it could come from an alteration of pleura. What was the function of pleura around the lungs? To help keep the lungs expanded, right? Good. They help anchor the lungs to the inner thoracic wall. What else do pleura do for our lungs? Protection against friction, right? Because they're lubrication. Good. As well as neuromuscular function plays a role, you guys, in restrictive pulmonary disorders. Because if someone can't adequately control skeletal muscles used to breathe, that's going to restrict their ability to ventilate. So it can represent acute or chronic patterns, which we'll talk about. And we'll talk about pulmonary versus extrapulmonary restrictive lung disorders. You know, the pulmonary restrictive lung disorders are the ones that are intrinsic to the lung itself. The extrapulmonary restrictive lung disorders will come from something outside of the lung, right? Maybe some external material that's accumulated around the lung, or maybe a neuromuscular disorder or a disorder of the chest wall itself. And we'll talk about those. So the first one we're going to talk about is the fibrotic interstitial lung disease. And this interstitial lung disease is just basically a group of disorders that are characterized by acute, subacute, and chronic infiltration of alveolar walls by cells, fluid, and connective tissue. And if left untreated, this leads to fibrosis or scarring. Now, the reason why this is a restrictive lung disorder is this fibrotic scar tissue decreases lung compliance. The lungs become less compliant. They're less stretchable. So it takes a tremendous amount more effort just to expand those lungs because they're less compliant. And this comes about from infiltration of cells, fluid, and connective tissue. Now, what we'll talk about here, you guys, is sarcoidosis. This is actually what Bernie Mac passed away from. You know, he's only in his 50s when he passed away, but he passed away from sarcoid. And it's an acute or chronic systemic disease that of unknown cause. What's odd is that it not only attacks the skin, but it also attacks the lung tissue. And what we end up with then are these little tiny granulomas that occur all over. And when they accumulate in the lungs, they restrict lung movement. So the pathogenesis then is where you have this sort of development of multiple uniform non-caseating epithelioid granulomas. But we don't know what causes it. Unfortunately, there's not even really very effective treatments for sarcoidosis either. It affects multiple organ systems. We'll talk about this again back in the skin, how it presents in the skin as well, not just the lungs. Hypersensitivity pneumonitis is basically an extrinsic allergic alveolitis, and it's restrictive and occupational disease, predominant non-smokers. But the pathogenesis is that there's a genetic predisposition to this. It's where antigen-antibody complexes can elicit this granulomatous inflammation, causing lung tissue injury. And this leads to diffuse pulmonary fibrosis, and this fibrosis, again, restricts the lung movement here. So it's a restrictive disease of immunological origin. So some of the different occupational lung diseases, you guys may have heard of these before because there's like classic class action lawsuits that you hear about advertised on TV. So like there's pneumoconiosis, which is where you have inhalation of inorganic dust particles. There's anthracosis, which is coal miner's lung or black lung. This comes about from inhalation of too much carbonaceous material. That's what they call it, the coal miner's lung, because that coal dust that would be kicked up while you're underground, like, digging out coal, when it accumulates in your lungs, it's difficult to remove. That's what we call anthracosis. You can get anthracosis from other sources, though. You don't have to be a coal miner to get anthracosis. Like, people living in urban centers also get anthracosis because of, like, organic pollution that gets kicked up in the air. We're always inhaling this, and we've all seen this, right? Like, you're coming out from the mountains, you look down into Denver, you see that nice, big, thick layer of haze that we're all living in right now. You're not aware of it because we're in it, but if you're outside of it, you see it really well. Well, within that is particulate matter, and that leads to anthracosis. If you look at the lungs of someone who's lived in the city for their whole life, they actually have a moderate amount of anthracosis. Not enough to cause disease, but it makes their lung kind of more darkly stained. We will see this at the coroner's office, absolutely. Silicosis, you guys, comes from silica inhalation. Silica is just one of those things, components of dirt and dust. So if you're working in some sort of occupation where there's a lot of dust being kicked up and dirt, that can lead to silicosis, and it's difficult to remove that silica. It's an inorganic compound. It can't be removed through phagocytosis really well, so it ends up accumulating in the lung tissue, causing interstitial lung disease. And then asbestosis. We talked about asbestos was a mineral you find naturally occurring on Earth. It's a great insulator, so you can still find it in older structures. And you can find it in the earth too. Like if you're digging a hole, there's a chance that there could be asbestos in the ground that you're digging at. So just something to keep in mind. But this asbestos is also difficult to eliminate too. So you might wonder, well, what are some occupations where someone will be exposed to asbestos? Well, nowadays it would be like remodelers or demolition crews, or even if you're still working in geological studies, or if you're a miner, you could still be exposed to asbestos. And I'm pretty sure I've seen this before too. One of my hobbies is like rock hounding up in the mountains, looking for minerals and stuff. And I've found these fibers that I think are asbestos, but I don't know. We'll see. We'll see if it ever catches up with me later on. So we're gonna next move on to the atelectatic disorders, you guys. And these atelectatic disorders are ones which cause partial or complete collapse of a lung or airway. That's what atelectasis is. Okay. So the first atelectatic disorder we're going to talk about is acute respiratory distress syndrome, or ARDS. This is where you have damage to the alveolar capillary membrane, causes widespread protein-rich infiltrates that cause severe dyspnea, shortness of breath. This decreases lung compliance from a lack of surfactant, also leads to fibrosis, and ultimately leads to disruption in oxygen transport. Okay? And you get these sort of diffuse, fluffy alveolar infiltrates. But the key here, you guys, is that due to destruction of the alveolar membrane, you can't make enough surfactant to keep your airways open, so then your lungs have difficulty expanding. They end up remaining kind of more in a collapsed state. That's why it's an atelectatic disorder. This ARDS would cause partial or complete collapse of a lung, depending on the degree of damage that's present. So what we see here then, you guys, is what the lung tissue would look like in someone with ARDS. So all of these spaces here are alveoli. And I can tell you what, all of this material here is not normal either. Normally alveoli kind of look like adipose tissue. We have a lot of circles with wide open spaces, right? What we see here then is this alveolus has been kind of destroyed, and you can also see it's thickened with a little bit of fibrotic scar tissue here. And all of this sort of red material are those diffuse alveolar infiltrates, which is basically like a protein-rich solution. But this comes about from destruction of the alveolar membrane. So basically this infiltration is just part of the extracellular material here that's been infiltrating the alveolar space here. That ultimately leads to the underproduction of surfactant and the difficulty of these lungs to expand. I'll give you guys an example of where you've ever experienced like surface tension of water. Have you had a circumstance where it's like you have a really cold cup? There's condensation on that cup, right? And you put the cup on a table. That condensation kind of settles on the base of that cup. And when you pick up on the cup, you'll feel there's a little resistance, right? It's almost like the water wants to hold that cup to the table, right? Have you guys felt that before? Maybe? Maybe not? Okay. That resistance there, it's basically the surface tension of water that's holding the cup to the table. It makes it more difficult to pick up on, okay? You don't really see that here in Denver because it's not humid enough usually to get a whole lot of condensation on glasses. But like Florida, heck yeah. Or where I'm from, yes, that too. But normally surfactant reduces that surface tension. So it reduces the stickiness of water. And if you don't make enough surfactant, then basically your airways can start to attract to each other. And it makes it more difficult to keep that airway open. So because the water's so sticky. And that can come about from damage to the alveolar membrane here. Okay, so that's more characteristic of ARDS. Now, this is also identifiable under an X-ray. And if you guys have experience with looking at like X-ray radiographs, what we see here then is all this sort of whitish material is more dense, and the darker material is less dense. And all this density are those fluffy infiltrates that have now invaded the lungs due to damage of the alveolar capillary membrane. Do you guys see this little thing right here? So it's basically a little centesis needle, and then what they're doing is they're going to draw some fluid out of that space to sample it, right? But they left the needle in place when they took the X-ray. That's what is that needle there around the lung. But you get this whiteout due to widespread damage of the alveoli. What's this white area in the center? Is there a lung there right in the very center of your chest wall? No, what is that? It's the heart. The heart's right in the center, right? You got a left lung here, right lung here. You got the heart. What about this stuff? What's all this down here? Yeah, liver, respiratory diaphragm, that kind of stuff. You can see ribs as well. So infant respiratory distress syndrome, or IRDS, also called hyaline membrane disease. Basically, it's a syndrome of premature neonates. So in premature births, what can happen is, we know that fetuses don't need to use their lungs, like, while they're in utero, because they're not breathing, right? They're getting their oxygenated blood from the placenta, which then gets its oxygenation from the mother's blood. So when these premature infants are born, they aren't quite ready yet to make pulmonary surfactant. But what was the function of pulmonary surfactant? Reduces surface tension. Good. So the primary cause of this is lack of surfactant, which means that you can't reduce surface tension as well, so that in these premature neonates, they have collapsed airways, which makes it very difficult to breathe. Now, there's different ways to reverse this. There's hormones that can increase the production of surfactant. Otherwise, doing like lung lavages with different surfactant-containing solutions can also help reverse this as well. But what happens, you guys, is that this generates really high intrathoracic pressures just to be able to ventilate. Like, they have to expand their rib cage dramatically just to inflate their lungs, because their lung airways are collapsed and they're sticky, which means it takes a lot of effort just to open up those airways. So that's IRDS. Now, we're going to move on to pleural space disorders, you guys. This is now getting away from the intrinsic restrictive disorders. Now we're getting to the extrinsic or extrapulmonary restrictive disorders. And so we'll talk about the pleural space disorders. Remember, the pleura are the tissues that surround each lung, and they help anchor the lung to the inner thoracic wall, but they also reduce surface tension in that fluid and reduce friction. Now, primary pneumothorax is an accumulation of air here in the pleural space. And pneumothorax can be spontaneous. We call it primary pneumothorax if it's spontaneous. If it's spontaneous pneumothorax, we're talking about air that's escaping from the lung itself. If you think about it, your airway is typically dead end at an alveolus, right? But what if the airway opened up into the external side of the lung? That means when you inhale, then air will leave your lung and start to fill the external space around that lung. Over time, that air can accumulate and form a big old pocket of air we call pneumothorax. If that pocket of air is too large, it starts to compress externally on the lung, and it prevents proper inflation of that lung. So that's why we call it a restrictive disorder. Now, primary pneumothorax occurs in tall, thin men, 20 to 40 years of age, and I think I'm pretty sure I have this, you guys, because every so often I get pain in my left lung. I know, right? Of course. Now, there's no apparent underlying disease factors, but cigarette smoking does increase the risk. I don't smoke, but I do fit this one right here. Now, secondary pneumothorax, you guys, results from complications of like pre-existing pulmonary disease. And we'll talk about the different types of pneumothorax. So this one's really weird. Catamenial pneumothorax. Catamenial pneumothorax is when you have endometrial tissue. Where do you find endometrium? Inside the uterus, right? The inner lining of the uterus somehow ends up around the outside of the lung. You might wonder, how the heck did that get there, right? Well, it's believed that maybe some of the endometrial tissue could leave through the fallopian tubes, enter the peritoneum, and then maybe eventually work its way up near the lungs. That's one hypothesis. Another hypothesis is that maybe the endometrial tissue is ending up in the bloodstream, and then once in the bloodstream, it can travel to a very vascularized organ like the lungs, and then kind of work its way out and eventually get around the lungs. But what's odd about catamenial pneumothorax, you guys, is that this tissue will grow and shed with normal uterine cycles. So that with catamenial pneumothorax, it's endometrial tissue around the lung. It'll grow, during the uterine phase, and it'll shed during the menstrual phase. You might wonder, well, that doesn't sound very good, right? To have like sort of tissue and blood and other things sort of building up around your lungs. Well, over time, that can lead to external pressure that can make it difficult for your lung to inflate, which is interesting. So we call this hemothorax because hemothorax means blood, in that particular space. And it's associated with endometriosis. Because remember, endometriosis is the displacement of endometrial tissue somewhere other than the uterus, right? In the fallopian tubes, pelvic cavity, abdominal cavity. Now this is the thoracic cavity. And we call that catamenial pneumothorax. It's kind of odd. Now, tension pneumothorax, you guys, comes from traumatic origin. So you can get tension pneumothorax, like if you have like direct puncture to the pleura, or if maybe just from overexertion the pleura tear on their own. Okay, so it can either be direct or indirect trauma. Now what we see here then, you guys, is up top is spontaneous pneumothorax. So remember, if it's spontaneous pneumothorax, it's coming out of the lung itself. So for whatever reason, one of your airways is actually opening up into the space outside of the lung. So when you inhale, take a deep breath, not only is the air entering your lung tissue, but it's also escaping out of the lung tissue and then surrounding the outside of the lung. So basically the air is filling the pleural space. It's filling that space between the visceral and parietal layers of pleura. And over time, that air can accumulate so much that it can start to cause your lung to collapse because of external pressure, which means it's difficult to inflate. Okay. Now with tension pneumothorax, it either can come from trauma, or it can come from just sort of overexertion, which can tear the pleura. But from trauma here, if you damage this parietal layer of pleura, then what can happen then is air can start to accumulate from sort of outside of the pleura now into the lung space here. And that exerts enough pressure then to cause the lung to sort of partially collapse. Now, a pleural effusion isn't an accumulation of air, it's an accumulation of fluid now, sort of in that space. And it's fluid or pus in the pleural space that results from another disease process. Normally you have 5 to 15 mils of serous fluid in your pleural space, you guys. This cap, like the cap on this little whiteboard spray here, this is about 5 milliliters, okay? So 1 to 3 of these things is all of the fluid you normally find around a lung, which is not that much, right? So typically the pleural fluid is pretty thin. It's a thin layer. And it makes sense because you don't need to have that much, just enough to lubricate as well as, help anchor the lung to the thoracic wall. But if you get more than that accumulating in that space, that fluid can start to have external compression on the lungs, which can also prevent proper filling of the lung tissue. So there's different types of pleural effusions, you guys. We've got transitates and exudates. Transitates are low in protein, and they're associated with things like heart failure. So let's think about this. If the left side of the heart's failing, where's blood backing up? In the lungs, right? If blood's backing up in the lungs, what does that do to pulmonary blood pressure? Increases it. Good. And if you increase pulmonary blood pressure, that can lead to increase in hydrostatic pressure, which can force fluid out into the lung spaces. Okay. That's a transitate there. So it's more of like filtered blood plasma. Exudate is actually going to be commonly caused by malignancies, infection, embolism, sarcoidosis, or post-myocardial infarction syndrome. These are more high in protein, and they're associated with like direct forms of tissue damage, where protein can end up then in that fluid as well. So emphysema here is actually due to infection in the pleural space, and it's a high protein exudative sort of effusion. Hemothorax is when you have blood in the pleural space. This can come from chest trauma, like if you get stabbed in the chest, and now blood's leaking into your pleural space. We call it hemothorax, right? But what was another form of hemothorax? Good, catamenial pneumothorax. Very good, you guys. And then we have chylothorax, which is basically the accumulation of fatty lymph in the pleural space. So we're still going to continue on with the extrapulmonary restrictive lung diseases, but now we're going to talk about the neuromuscular disorders that might prevent proper movement of the lungs, right? We know the lungs can't just move on their own. Lungs have to be pulled upon, right? Or if the muscles that pull on the tissues that are associated with your lungs, the lungs can kind of relax back to a resting shape. But if you have a neuromuscular disorder, then it's going to be difficult to inspire or inhale because you need to use muscles to expand that thoracic cage, okay? So the first type of neuromuscular disorder we're going to talk about is poliomyelitis, right? So caused by poliovirus. It's a demyelinating disorder that affects motor neurons. And because these motor neurons can't transmit action potentials very well, the skeletal muscles that are involved with ventilation then aren't being excited as often. So what ends up happening then is these individuals can't properly expand their thoracic wall in order to ventilate. So this manifests as sort of weakness and paralysis, which comes as a consequence of the polio. But you also see respiratory failure with more advanced polio. and chronic respiratory insufficiency from previous disease. So this is referring to post-polio syndrome. You know, polio was common 50 years ago. You know, there's a vaccine for it now, so you don't see it that often in this country. But for those individuals that had polio prior, they survived, but then years later, because of the neuron damage they had, you know, maybe decades prior, they end up getting weakness later on in life because those motor neurons are now kind of more damaged from the previous infection. So they age faster, which means they're weaker, and then you get respiratory insufficiency because they have difficulty expanding their thoracic cage. It's not because the polio came back. It's just that the damage that polio caused caught up with them sooner. So it caused their nervous system to age more quickly. We call this post-polio syndrome. A lot of this popped up in the 80s from people who had polio like in the 50s and 60s. All of a sudden, people started exhibiting symptoms of polio, but they had no active polio infection. It's just because that their nervous system aged more quickly as a consequence. Now, one thing you can do for respiratory failure, you guys, if it's respiratory failure associated with ventilation muscles, is if someone can't ventilate on their own, you can put them on a ventilator, right? And so there's different forms of ventilators. There's ones that can just sort of force air into your airways. You know, it's directly hooked up to their respiratory tract. Or you can put them in an iron lung, which is more common for, like, you know, back in the day when we had polio patients. So what this picture is showing is an iron lung, and it's basically a big old pressure chamber, right? So what this pressure chamber would do then, you can see the pressure gauge here, is it would add positive pressure and then to have negative pressure. So it would actually add positive pressure for exhalation, because if you're adding pressure to this chamber, what you're doing is you're forcing air in there. That air then is going to bear down on their chest and then force them to exhale. When you draw it out and you create a vacuum, then their thoracic cage is going to expand within this iron lung, and when your thoracic cage expands, then air gets drawn inward. Okay? So sometimes people would need to kind of hang out in the iron lungs for months or years until their polio resolved. But how amazing is that? So this is showing one of those iron lungs. Have you ever heard of an iron lung? Now you know what it looks like. So it's just a big old pressure chamber. So, oh, by the way, check this out. They have their head exposed, and they got a mirror here. That way they don't only have to look up at the ceiling. They can look in this mirror and see like something behind them, but it would still be upside down. So it's kind of interesting. Now, another type of neuromuscular disorder is amyotrophic lateral sclerosis, or ALS. You guys may have heard of this before. So males are often more affected than females, and it's a degenerative disease of the nervous system. This leads to progressive muscle weakening and wasting. And what happens then, you guys, is that it affects the lower motor neurons. And so not just muscles that are involved with ventilation, but also muscles of your extremities start to become more weaker over time. So it's going to start out as like, peripheral muscle weakness, and it'll progress more centrally, including respiratory muscles, where eventually, once this disease has progressed enough, then they can't ventilate on their own. Okay. Now, they don't die directly from the ALS. What they end up passing away from then is like respiratory failure or, pressure ulcers because they're bedridden, they can't move on their own, right? And what's really sad about this disorder is there's no cure for it. There's just basically supportive therapy, just making sure someone feels comfortable as they sort of start to waste. And sometimes this can progress very rapidly. From the onset of diagnosis until death could be as short as a year. So that's why it's such a sad disease, because once you're diagnosed with it, you have a very short period of time. Now, we'll talk about the muscular dystrophies later on when we get to neuromuscular disorders, you guys. But just for now, you guys, we'll talk about how they're hereditary. They're X-linked recessive, so mothers can pass this to their sons. If it's X-linked recessive, who's going to be most often affected? Males or females? Males, right? Because males only have one X chromosome. So in order for a female to have muscular dystrophy, she would need to inherit a defective copy from either parent, which would both need to be carriers or also affected with muscular dystrophy in order to have this. So it's most often males, okay? So it's this progressive muscular weakness, and it's due to disruption of the muscle cell membrane. The muscle cell membranes are weaker, so they break down more quickly, so they actually get progressive muscle wasting. There's different forms of it we'll talk about, you guys. There's some forms of it that are so severe that someone's wheelchair bound by the time they're 13. There's other forms of it that are less severe that can kind of pop up in the 20s and 30s, or even other forms that only affect like the face and neck muscles, and limbs aren't affected though. So it's kind of interesting. But if it affects respiratory muscles, then that's going to lead to hypoxia, hypercapnia, because they have difficulty ventilating, as well as respiratory infections because of reductions in airflow, right? Like if you have pockets of air in your lungs that are very hypoxic, then it's going to set up a great condition for anaerobic bacteria to start proliferating and dividing and causing infection. Guillain-Barré is a demyelinating disease. It seems to be viral in origin, possibly bacterial. And what ends up happening, guys, is that you get this progressive demyelination of neurons throughout the body, mostly peripheral neurons, but that also affects respiratory muscles. So these individuals have difficulty ventilating, as a result. Now, what happens with more severe cases then is these respiratory muscles can become weakened, and that can lead to respiratory failure. Now, most people who are afflicted with Guillain-Barré typically have a full recovery, right? So it's typically not like a fatal disorder, but you can lead to sort of temporary muscle weakness for maybe a year or so. And then for most people, only 15 to 20% of those who've had Guillain-Barré have some sort of minor motor residual deficits, if that makes sense. But it's a pretty common demyelinating disorder. Myasthenia gravis, you guys, is an autoimmune disease. So it means your immune system's attacking some sort of part of your body's tissues. So with myasthenia gravis, what ends up happening is your immune system creates antibodies against the nicotinic receptors on skeletal muscle. So what ends up happening here then is that these antibodies block the nicotinic receptors on skeletal muscle, so they can't respond to acetylcholine. And then what ends up happening is that they can't really control their skeletal muscles very well, including respiratory muscles. Okay, so then you see this sort of muscle weakness that's associated with this. So if it's an autoimmune disease, how do you guys think this would be treated then? Yeah, immunosuppressants. You got it. Or plasmapheresis, right? Where you can remove antibodies from someone's blood plasma. That's reversible. Now we're going to move on to chest wall deformities, you guys. Now, chest wall deformities can also limit how well your lungs can expand based on a variety of factors. And the first one we'll talk about is kyphoscoliosis. Kyphoscoliosis is basically where you have a deformity in the chest wall, which comes from either kyphosis or scoliosis. And it's caused by a deformity in the vertebral column. So kyphosis is where someone kind of is bent forward, they're kind of hunched forward. Scoliosis is when their spines bend to the side, and then there's lordosis where they're bent back too far. But all of those can affect the ability to ventilate because it's going to put odd pressures on the thoracic wall, especially with things like kyphosis and scoliosis. Like if you're hunched over a lot, it's going to be difficult to expand that chest wall, right? Or if your vertebral column is bent, your ribs might not be able to expand as well because they're bent in lots of different directions. So that's what this slide's showing here, you guys. So this is an example of kyphosis, where she's sort of hunched forward. Over here, you're seeing scoliosis. So you can see that his spine is sort of curved laterally. And we'll talk about the different subtypes of scoliosis later. But when scoliosis affects the thoracic vertebrae, then you're talking about the thoracic area, and it's gonna be difficult to expand your rib cage if the vertebrae are bent. So that also causes a restrictive pulmonary disorder. Another thing that can actually also restrict proper ventilation, you guys, is an autoimmune disease called ankylosing spondylitis. So ankylosing spondylitis is more common in males than females. The cause seems to be unknown, but it's believed to be immunologic or autoimmune because there's actually different genetic markers for this. Like if someone has HLA-B27, this seems to be more highly associated with ankylosing spondylitis. And what we find here with ankylosing spondylitis is that you get slow fusion of the vertebrae starting in the lumbar area, working its way all the way up the spine until the spine is basically one big fused bone, if that makes sense. So let's think about this. If you take a really deep breath in, and you think about what your spine's doing while you do that, you can feel that your spine's actually expanding with your thoracic cage. Well, what if the vertebrae are all fused? Then you're basically going to be stuck in position. It's really difficult to ventilate that way, right? So ankylosing spondylitis also leads to restriction in proper ventilation. Now, flail chest. This one sounds so ridiculous, you guys. Like I feel like it's like someone made this up. Like, oh, you got the flail chest, right? Like it sounds like something you would see floating around in some sort of, blog. That's some like made up health blog. Like, careful of eating beets; they cause flail chest, right? No, this is actually this is actually like a real. This is actually a real disorder. Now, what's odd here, you guys, is that it comes about when the ribs are fractured in two places. It's a complete fracture. So I'm talking about where the ribs might be fractured at the proximal and distal side, or posterior and anterior sides of one rib. So now you have a loose patch of ribs here. Okay. Now, when you have a loose patch of ribs, what happens when you exhale? It's going to protrude out, right? Or when you inhale, it's going to suck in. So what's unfortunate with this flail chest, first of all, not only is it painful, but it also does the opposite of what the rest of your ribs are doing. And we know that with proper ventilation, it's all about changes in volume, right? So when you increase the volume of your thoracic cage, you increase the volume, it decreases the pressure, which allows for air to flow in, right? But what if you have flail chest, and now when you inhale, instead of all of your ribs expanding, there's a patch of ribs that's actually sticking in. So it's actually doing the opposite of what you want to do to properly ventilate. And so by actually sticking in now, kind of being sucked in, it's actually not increasing the volume. You're actually decreasing the volume, so you don't get a proper amount of ventilation. Or what about when you exhale? You're trying to decrease the volume of the thoracic cage to increase the pressure to force air out. But with flail chest, when you exhale, instead of all your ribs kind of decreasing in volume, now this little patch of flail chest rib piece can protrude out, and it's actually helping increase volume. So it's doing the opposite. So it doesn't help you ventilate. Actually, it's going to make ventilation much more difficult. On top of the fact that it's painful, right? You get this little loose patch of rib there that's floating around. So that's what they call flail chest. It's a real deal. It's like a real thing. I know it sounds ridiculous, right? Like raccoon foot or pig nose or something, like just something really weird, right? Like some sort of like Appalachian disease that just seems made up. This is a real thing though, flail chest. I just think it's funny. Like I wish there was a better word for it, but hey, I guess it kind of makes sense because it's kind of flailing around. It does its own thing. In fact, it does the opposite of what you need it to do, which is unfortunate. Obesity can also restrict proper ventilation as well, you guys. Think about it. If there's a lot of weight on your thoracic wall, especially when you're laying down, if there's a thick column of adipose on your thoracic wall, that's really bearing down your chest, and it's going to make it more difficult to ventilate. Okay, and I've seen this before. We might even see this at the coroner. But back when I used to dissect cadavers, you guys, the first thing you have to do was deflesh. Take the flesh off the cadavers, so you just cut their skin off, including the adipose deep to that. And I've seen cases where someone's adipose is like this thick, like a foot thick or more, and it's tremendous. But it makes sense though. That's a lot of additional weight that can really bear down their chest, and it can make it more difficult to ventilate. So that can lead to sort of obstruction of the airway, or at least restriction of that airway. It's also associated with sleep apnea because think about it, adipose in the neck or elsewhere can kind of start to protrude on airway structures. And sleep apnea is the cessation of breathing while asleep, right? So it can cut off airways, and that can also make sleep more difficult, right? If you stop breathing while you're sleeping, and all of a sudden you wake up just to take a big old inhale because you've been choking, for maybe a minute or something, it's going to be difficult to get a proper night's sleep. And then all the health consequences that come with that, right? So it's kind of interesting. Now, infection and inflammation can also lead to restriction of proper lung function. And so we'll talk about pneumonia here, you guys. Now, pneumonia is inflammation of the alveoli and interstitium caused by some sort of infectious agent. It could be a community-acquired, hospital-acquired, bacterial, atypical, viral. Guess what? I had this one too. The one I had was community-acquired. And I can tell you guys, just from personal experience, it's not fun. You don't want to have pneumonia. Imagine being winded just walking from your car to this classroom. Or imagine being winded just trying to go up the second story here. Okay, and then you stay winded for a period of time after that. Now, this was one of my first semesters teaching, and I had pneumonia. It wasn't, talking requires a lot of breathing, and I get out of breath really easily. I'd hold on, guys. I had to take breaks to breathe, which is unfortunate. And because my blood oxygen levels were low, it was also difficult to think. So it wasn't fun. Let's put it that way. But the pathogenesis of pneumonia, you guys, it's acquired when normal pulmonary defense mechanisms are compromised. Organisms enter the lung, multiply, trigger pulmonary inflammation. These inflammatory cells will invade the alveolar septa. These alveolar spaces fill with exudative fluid, and it makes it more difficult to also cough out. Now, viral pneumonia doesn't produce exudative fluid, though. Now, you guys may have heard of SARS, severe acute respiratory syndrome. It's associated with a coronavirus, SARS coronavirus. And the primary mode of transmission here is person to person. It's spread by respiratory droplets, so people coughing, sneezing, that kind of stuff. This is why you see individuals wearing face masks a lot of times if they live in urban centers, as they're trying to avoid respiratory infections like this. And so contact with contaminated objects or surfaces, touching your mouth, nose, and eyes can put you more at risk for something like SARS. Although we haven't heard about this in a while. But, these things can always come back. In fact, it's zoonotic, right? So, like, SARS or this coronavirus doesn't only infect humans. It's also associated with livestock. And that's how it's believed to transfer to humans, is that it was spreading around livestock, but people living in close quarters with livestock were, being infected with this virus, and then it spread from human to human after that. Tuberculosis, you guys, that's bacterial. It's caused by Mycobacterium tuberculosis. About 10 million people in the United States are afflicted, right? So you're talking about 0.3% of the United States population. That's quite a bit. So just shy of 0.5% of all the people in the U.S. probably have tuberculosis infection. And, since this was published, it might even be higher. Now, some high-risk individuals will be people who've had prior infection, right? If they're immunocompromised, if they're malnourished or immunosuppressed in some way. Living in overcrowded conditions can put you at risk for TB. Incarcerated persons, again, because it's overcrowded places. If you're from a different country, and elderly, they're all at risk for tuberculosis. In fact, there's parts of the world, you guys, where there's like triply resistant tuberculosis now, where it's tuberculosis strains that are resistant to all three major classes of antibiotics we can use to fight that